morning, everyone. Amy has been too generous with her presentation, so you will figure it out along mine. Or whatever she said is absolutely exaggerated, so I will be very much on my toes to try to describe to you what is the recent effort that our institution has put in through to generate these new models. So I will give you some example of what I think perhaps this new strategy will help us along the way to improve molecular knowledge and biological knowledge on lymphomas, and more importantly, to define potentially new therapy and use those in a more clever way. We are all aware that we are not very efficient in generating, commercial drugs, and the number of compounds that they are screened are really humongous compared to the one that enter in the clinical arena, and the cost is absolutely outstanding. If that money could be used in a clever way, we will definitely improve our medical practice and probably the life of many individuals. So I think that we have a moral duty to figure it out how to improve this, and embracing, a different, getting out of the box and try to figure it out if we can do a little better than what we are doing. So this is very well recognized now for a decade or more by NCI, American NCI, and the Canadian NCI. This is an editorial that came up a few years ago pointing out that, unfortunately, a lot of the drugs are not capable to get in the market. We have major problems along the way, and probably it will be better to improve our preclinical models and drug discovery programs. So today I will focus in mouse model a little bit, in particular in PDX, so patient-derived xenograft, because we believe that this may improve our practice. So conventionally, there have been developed over the last, I would say, 70 years, many mouse models, and with different flavors and different characteristics. And all of them, including the PDX, they have definitely handicaps, and we need to somehow understand how we can move forward. Probably genetics on a different background that will improve our mouse modeling, in particular the capability to rapidly engineer mouse using this new technology that is now called CRISPR and Cas9 will probably allow us to improve definitely much more than what we have done in the last probably 50 years. So a lot of the xenograft model have been developed in highly immunocompromised animals, and along the way, several animals have been developed. I would say the milestone has been achieved by two groups, a Japanese group and an American group, in particular a private company, the Jackson Laboratory, that developed this very highly immunocompromised animal. They don't have B and T cells, and the NK, they often impair the implant of primary tumor, or at least they allow the selection of highly aggressive tumor have been somehow knocked out using a conventional genetic approach. On top of this, many groups now, they have engineered, humanized mouse that they express a specific human compounds, a human chemokine and lymphokine, that they are believed to improve our engraftment rate. In fact, if you look, the result of solid tumor is very impressive, what has been done in the last few years. And in the last issue of Nature Medicine, Novartis is presenting the data on over 1,000 PDX model and their pharmacological evaluation. So the field is really moving fast. And in the case of lymphoma, we are behind, and we need probably to move a little faster. But this implies that we need to understand, for example, the relationship between tumors and the host, something that is very unique in the lymphoid compartment. There are plenty of pros, and there are a lot of cons, and these are definitely impairing our capacity, but we have now technology, and we should be able to overcome some of them, and I will present a little bit of this. Now, this is very popular. There are probably over 30 companies in the world that are generating patient-specific, models, some commercial, some academics, and NIH has developed a new program to foster this and is highly sponsoring new model in the call of the RFA Recently, the NIH is sponsoring a specific program to develop mouse model in different contexts to understand clonal heterogeneity, dynamics, and so on. And even major institutions like the Mayo Clinic, they partnership with a Chinese company in this case to generate PDX in patients that are coming in their institution and to use those as a model to improve therapy. Now, here in our institution, we have a dream. This is the dream depicted in this cartoon. The idea is really to take a sample from the patient and develop models that eventually will inform us on that particular individual, or more importantly, in a particular subset of the individual, because it's very unlikely that we'll be able to generate PDX for every patient. But if we generate PDX that they represent a single subset of individual, maybe we can do a better job. Now, the program compiles many different programs and with different malignancy. Today, I will just give you a few examples of the heme malignancy. So I will present you our mouse suite. The VIP mouse suite has been a lately achievement of our institution with a very high cost. So the mice are in a completely GMP facility, and I will go through very fast a couple of slides to show you what have been generated. And each individual mouse lives in a ventilated cage, completely separated by the others. They are handled by specialized individuals. This is a very highly costly operation. And we have also acquired novel instrumentation. This is, for example, was a beta site MRI that I somehow helped to develop in Italy, and now is in our institution. So it's a real intensive care unit where the mouse is anesthetized. We can follow EKG, breathing, temperature, and so on. And we can perform a live MRI with different dyes and so on. I will focus on T cells because this is our area of interest for my group, and I think there is a great need to generate mouse model in T-cell lymphomas. Unfortunately, we have plenty of cell line for lymphoblastic, but we don't have anything for mature T cells. So we started a long time ago to develop this program, and lately, with the help of other groups, we have been awarded by the Leukemia Lymphoma Society for this particular program, and most likely we will be helped also to develop a similar program for the Bcell. So the idea is really to generate informative data using different models, 2D and 3D, and eventually mouse, and use those models to develop new drugs. The way that we generate these animals is really complex sometimes. Here there are a few examples. The most convenient one, obviously, is the subcute, but we can implant intraspleen, intraliver. For the multiple myeloma that we just started, we are doing an intrabone injection of multiple myeloma, purified cells in combination with hosting cells. And the mouse is characterized using many different technologies, including molecular. We are doing liquid biopsy, MRI, as I mentioned before. This is a classical example. The mouse, multiple mice are implanted. They're expanded over time, and we can analyze and characterize this tumor along the way. And I will show you a few examples. So these tumors, they behave really like a human. If implanted is subcute, they may grow subcute. Recently, we have developed angioimmunoblastic T-cell lymphomas where they are implanted subcute, but they don't expand, but they colonize all the lymphoid organs. And this is an example of an aplastic large cell lymphoma that implanted subcute has colonized all the lymphoid organs first and later parenchyma, including spleen and liver and so on. But one notion that is very clear in my mind and sometimes is not very well developed in the literature is that these animals, they are not exactly the same as the primary tumor. And we need to know the limitation to draw any kind of conclusion. So I had a beautiful slide from NCI, much better than this one, but I was told that I could not present it because it was an NCI slide. So I modified this and I took picture from an Italian newspaper, but I think the idea is quite clear. So the easy way to characterize immunohistochemistry, these tumors are maintaining their original phenotype. They invade the organs. They can be easily followed by immunohistochemistry, for example, flow cytometry. And in gene expression profiling analysis, and more recently in RNA-seq data, we can prove that these particular PDX have a unique signature. And more importantly, this signature, they are recapitulating the expression profile of individual subset of, in this case, anaplastic large cell lymphoma. So this model may be representative of this group of individuals that they have a very unique clinical evolution. Now, based on exome sequence analysis, we can follow the progression of this clone in these animals. This is an example. So here we have one sample versus the other. All the dots that you see are variants, genomic variants. They are in common with the two different tumors that are analyzed. And you see there are a lot of commonality, and this is true for many models. But sometimes we see, for example, this is a late passage, is a T9 passage, so this tumor has been passed 9 times. We have now the emergence of individual mutation that they are unique on that. And so we can follow clonal evolution in these animals. And this is a representative slide where we have the variants that are present in the primary tumor, and there is a certain variability in the PDX. But in this case, we have constant variant that they remain over the passages, meaning that either are driving mutation or close by to driving mutation are very stable point. And here we have new emerging mutation that they come up with a certain frequency in these animals. And now we are characterizing those to figure it out if there are new oncogenic defects. This is another example that we published some time ago. This is a new translocation, quite rare in the field of anaplastic large cell lymphoma, where the first 5' end of this chimera is generated by a TRAF1. And the interesting part of this molecule, that this part of the chimera is capable to turn NF-kappa B very effectively. And therefore, we have now a dual functional oncogenic protein where we have a conventional conventional signaling through ALK and here NF-kappa B. Now, if these animals are treated with a crizotinib, or in this case, a CHAP22122, that is a specific inhibitor of ALK, we have pretty good response. These are the response. But in many of the animals, we develop rapidly refractory phenotype, and we never cure the animal. And the reason is because we need to combine multiple drug to overcome the phenotype of this tumor. This is another example. This is an ALCA minus ALCL, where we found a deletion of NF1 with a new fusion on NF1 that basically breaks apart the coding region of NF1, so we have a total loss of NF1. And in this particular case, we have a RAS signaling pathway that is turned on, and if we treat the animal with a MEK inhibitor, we have a pretty good response. So these are clear indication that if we have a genetic defect, we can target with specific compounds. Now, what about a clinical response and a prediction response in the patient? So I give you 2 examples that I already presented many times, but I think are very clear indication of the power of this model. This is a model that was developed by a lady with anaplastic large cell lymphoma. This lady was treated with conventional CHOP. She responded very well, but rapidly relapsed. And that was seen for 3 times. The end product was her death, unfortunately, in a compat toxicity protocol. This is the tumor that we generated in this particular individual. So the tumor grows in the animals, is treated with CHOP. There is a pretty good response and relapse. This is contralaterally an individual that was ALK minus CHOP resistant. Here we have no response. We have a conventional protocol analogous to this. Now, if we take these tumors and we reimplant it, we can reproduce over and over up to 7 passages that the tumor is responsive to CHOP by relapse every time. But now we need to be clever, and clever is, this is a tumor ALK positive. This is a tumor that was generated many years ago. We didn't have crizotinib. We use a 28122 that is an inhibitor for ALK. Here is the response. We have a pretty good response with low masses and even with large masses, and the end product is the mouse is totally cured up to a year. So these are informative models. What about, for example, CD30? It was not commercial at that time. We learned very rapidly that the response of CD30 in this animal is very much related to the tumor burden. And if we combine now CHOP and anti-CD30, we have cured the animal. So very similar what is now in design of the clinical trial. So we did a long time ago before the trial was designed. We recently identified recurrent mutation in JAK and in STAT in a series of anaplastic ALK minus. And if we now take a PDX that they have, in this case, double mutant, so JAK and STAT, and we treat it with an inhibitor of JAK1, JAK2, we have a response, no cure, but we have definitely a control of the growth. So this is a potential way to analyze target mutation. Now, can we implant any kind of tumor? It's very hard to implant non-aggressive tumor. This is probably an exception. This is a cutaneous LCL we recently developed. It was a very large mass in the inguinal area with involvement of the node. Oops. With the involvement of the node. So the node was the local inguinal node were involved. The patient responded quite well to initial, but he was relapsing and relapsing either with conventional therapy or with CD30. And this is our PDX. So he grew actually relatively fast in a couple of 8 weeks. This is quite unusual for a low grade. And he has a histological feature. They resemble the one of cutaneous ALCL with infiltration of the skin and adnexa and so on. The phenotype is exactly identical to the original primary tumor. And now when we treated, having demonstrated that the mutations seen in the primary tumor are totally preserved in the PDX, exactly in the same position with the same frame shift of somatic mutation. Now when we treat it with a CHOP protocol, we have a substantial amount of animals that relapse, but with a conventional one single cycle of brentuximab, we have a pretty good response and very late relapse. This is exactly what happened in the patient, so it's quite interesting. Now, moving forward with more complex, this is an angioblastic Tcell lymphoma. These are very difficult tumor to be analyzed. There are very few models in the literature. And so this is a tumor that rapidly invades organs. And here we have, for example, a colonization of the heart of tumor cells. And when we treat these animals, we can follow very nicely the presence of leukemic cells in the peripheral blood of this animal. And this is a CHOP treatment, so we have a substantial response. And when we combine ASA plus CHOP, we have a better response and prolonged survival. Now, 2 words on Bcell lymphoma. This is an ALL model. I will present one ALL model and one diffuse large B-cell lymphoma model. This is our ALL dasatinib resistant. So we have now, dasatinib sensitive. So we have now implant of the through IV of acute lymphoblastic leukemia. We treat the animals. We have pretty good response. Now we use high-dose dexamethasone, and we can put the animals over time in clinical remission. What about immunotherapy? This is a bifunctional antibody, anti-CD19, CD3, in combination with cytotoxic inducer killer cells. It's a long protocol. I just want to make a point that CHIK cells, they are capable to control initially the disease, but the disease will progress eventually. The control will die very fast, and in presence of the bifunctional antibody and professional effector killer cells, we have cured the disease in this animal. This is a very aggressive model. 2 words on Richter. We generated a couple of Richter models. They are very highly mimicking the original sample. And also in this case, using a CD19, CD3 bifunctional antibody, we have eradication of disease. This is a PFS, so we have a prolonged survival. We killed all the animals, unfortunately, to see if there was disease, and the disease was not present. Last slide, and I finish with my presentation. This is a diffuse large B-cell lymphoma, highly aggressive lymphoma with multiple genetic defects. This is a work that was done by Leandro Cerchietti. So the tumor were explanted in culture. He defined the IC50 of this particular compound that tag this gene that is in this case amplified. He defined the IC50. The animal now are treated, and we have control of disease. So I think that these models are moving forward. It's only the beginning. We have to learn. It's a very highly costly operation that requires the integration and the networking of many institutions. And this work and many other studies have been developed by a very large number of individuals, first in Italy and now later on in the United States, with the help of many different associations. And as I mentioned before, we have now gained the support of the Leukemia Lymphoma Society. Thank you very much.